This is the first kind of venture that we know we have seen didactic lectures, we have seen seminars, symposium, panel discussion, and didactic lectures were easy to prepare. I thought when you enter gastroenterology, the best possible publication one has to remember, and one will be able to quote it offhand. What are those publications, any given topic? I thought over that. When Govind had organized Young Masters program, that a thought I got generated. Then I thought we should have 10 best papers in each topic. It's the reason why we made it 10 landmark publication gastroenterology. And the first series, initially I thought I will do one thing. So I called Dr. Shivsarin to talk on hepatology, and Dr. Nageshwar Reddy on endoscopy, and Vinith Ahuja on luminal. And seeing the response all over the world, I thought we should have a series of webinars. That is the genesis of this. Initially, it's a broad topic I gave it in hepatology, in luminal, in endoscopy. Now I am focusing on organ specific, small bowel, biliary, pancreas, and endoscopy imaging, US, something like that. I thought this is what. Those who are not able to attend, they can see the YouTube link later on also. Number one. Number two, why not we bring out a book on this webinar series? So I am going to bring out a book on landmark publications in gastroenterology. So my humble request to the speakers to give permission to share your slides. And we have for the organizing secretary and joint secretary who will note down your comments also. The book format will be, first one page will be the abstract of the paper which you are presenting. And the backside will be what are the comments you are making. Say now Mahesh is telling 10 papers, 10 papers, comments about 10 papers. The tough job will be the speakers. Now just now the Dr. Mahesh told me and Dr. Govind, but both of them appear to enjoy this. This is what they feel, I mean the impression by Dr. Shivsarin and Dr. Nageshwar Reddy and Vinith Ahuja. And this is not a regular run-of-the-mill lectures. We need to prepare. The other tough job is the commenter. He has not been exposed to the kind of publication which you are going to tell. So he has to be very attentive and note down the comments you are making, and you have to make a brief the impression about this. And anyone who cares for gastroenterology would be interested in knowing these publications. This is what I have made it like that. And can we start the program, Mr. Swashkar and Jairaj sir?
Yes, okay. Sir, we can start now. Yeah.
I'm going to run one or two slides on this. What slides?
Mahesh, good evening. Ajay, hi. Jairaj sir, hello.
Sir, good evening, sir. How are you, sir?
Yeah, great. Nice. Mahesh is all tensed up about his talk. Hi. Sunta nahi. Yeah, yes. Yes, Mahesh.
Yeah. Okay. I will just introduce this 10 most impactful landmark publication gastroenterology. The question here is, sir, can we choose it in last 1 year, 2 years? No, that become a journal club. So what has really created an impact in terms of change in the path in the gastroenterology and change in the management? So this is what the 10 most impactful landmark publications in gastroenterology. And this webinar series by MedIndia Hospitals and MedIndia Academy, which is affiliated to the Tamil Nadu Dr. MGR Medical University. I'm glad to inform you that the Tamil Nadu Medical Council has awarded 1.5 credit hours. That's a very important thing. So whoever is attending, both faculty and the delegates, will give the e-certificate. And the first webinar, as I told you, the speakers were the eminent stalwarts and Sarin, Nageshwar Reddy, and Vinita Giza. And that is the stimulus to go for the second series. Here, Dr. Mahesh Goenka and Dr. Govind Makharia will be the speakers. I have a great pleasure in introducing Dr. Ajay Kumar, who is the president of Indian Society of Gastroenterology and has been the president of Indian Society of Gastroenterology and Endoscopy of India. He's got a very keen interest in academic activities. He has published several publications and he started his dependent program in his own unit. And he is very familiar. And recently, he has been awarded by American Society of Gastroenterology and Endoscopy award. And he is the right person to take up the first topic. He will introduce the speaker, Dr. Mahesh Goenka. He will conclude the first topic. While before handing over the mic to Dr. Ajay Kumar, what are our futuristic program? We have, as I told you, every month, last Friday, we'll have landmark webinar series. Series 3 is on pancreas. Since we have more inclination for endoscopy, the one topic will be pancreatic endotherapy. The other one is the acute and chronic pancreatitis. The faculty will be intimated. The format will be like this. In October, last Friday, we are focusing on biliary diseases, stone and stricture and biliary endotherapy. In November, we are going to go for now. As we are advancing in therapeutic endoscopy, it is needless to say the endoscopy diagnostic imaging also and functional GI diseases. And the last week, last Friday of December will be upper GI diseases and colonic diseases, mainly on IBD. Again, the focus is on landmark publications. And the next year, the third space endoscopy and interventional UES will be there. So please note down every time the Friday between 4 and 6 for landmark webinar series is on hepatitis B and alcohol hepatitis and NASH. And it's my desire to bring out a book on all these publications and the contributors and their comments. So in one go, a postgraduate student or a senior most consultant can go through what are the best publications, the impactful, he can go through it. That will be a great stimulus for our students and a recap for our consultants. You get CMA credit hours from Tamil Nadu Medical Council and we will send the e-certificate. And the certificate will be mailed like this, webinar certificate and the faculty or delegate. The e-certificate of participant will be emailed to registered delegates. This would not be possible, even though I am focusing, I am the Facebook of this organization. This was possible because of Dr. Gokul, Dr. Satyamurthy, Dr. Raja Yogesh, Dr. Prasad, and a generous grant from the Micro Lab Knowledge Academy. With this, I will hand over the mic to Dr. Ajay, and later on I will introduce Dr. Mohan Prasad and Dr. S.P. Misra. The mic is, I will hand over the proceedings to Dr. Ajay Kumar. Thank you.
Thanks, TST. Am I audible?
Yeah, yes. Yeah, you're very much audible.
Thanks, TST. Well, friends, this is one of its unique scientific program. We keep on having different lectures, meetings, and so on. As Dr. T.S. Chandrasekhar has already said, it's one of the most unique programs. And he also told that the most difficult part is of the speakers and the commentators. And actually, my job is the easiest one because my job is to introduce the speaker and the topic. Well, why it has become easier? Because speaker is one who doesn't require any introduction. All of you are familiar with him. Dr. Mahesh Goenka, dear friend, and he's a chairman gastroenterology at Apollo Hospital in Calcutta. And of course, he's the past president of Endoscopic Society of India. And of course, all of us know, at least people all across the world know, he's a great organizer who recently organized Asia Pacific Digestive Week in the end of 2019. He's a great academician, great clinician, great organizer, and great research worker as well. Well, the topic is very clear. It's already said that the 10 most publications. So Dr. Chandrasekhar has divided the whole small bowel publication into two separate parts. One is the imaging or the evaluation of small bowel. And of course, that's what Dr. Goenka will present. And so I'll straightforward go to Dr. Goenka and request to start his presentation so that we can all have benefit. Actually, I'm today as keen a listener as anybody else to learn from what he speaks. Over to Mahesh.
Thank you, Ajay. Thank you, Dr. Chandrasekhar, for organizing this meeting and for giving me a chance to be here. Am I audible?
Yeah, you're audible, Mangesh.
Okay, so I would dedicate, with the permission of Dr. Chandrasekhar, this particular session to a dear colleague, Dr. P. Murali Krishna, who was Joint Secretary of SGI when we untimely lost him very recently. Why I'm dedicating it to him is he is one of the pioneers we all know for starting small bowel evaluation by enteroscopy in this country. So we all know that till about 20 years back, small bowel was a dark area for the gastroenterologist. With the advent of these four modalities in the last 20 years, we have advanced quite a bit. And I think that's my job, to take you through the journey by means of landmark publications over these four areas. I've also been given the job of covering some of the imaging aspects also. So before I start my presentation, let me recapitulate for all of you that what are the indications for small bowel evaluation. Suspected midgut bleeding or iron deficiency anemia, diagnosis and evaluation of Crohn's disease, tuberculosis, and other disorders, small bowel tumors, polyposis syndrome, and more recently, biliopancreatic interventions in altered GI anatomy. This can be done either by imaging techniques or by endoscopy. So when Dr. Chandrasekhar gave me this job about 2 weeks back, my first thing was to go into PubMed search, and I looked at small bowel evaluation. And to my surprise, there were 142,000 articles published on this. I then narrowed down my search to small bowel endoscopy, and yet there were 30,499 articles published for small bowel endoscopy. So it was a tough job. So it came into my mind that let me look at Dhoni.
Not audio. Yeah, the video.
So these were all excellent sixes, but this is the landmark. This is World Cup 2011. Dhoni is batting. India needed 5 runs, and this is a 6.
India lift the World Cup after 28 years. The parties start in the dressing room, and it's an Indian captain who's been.
So the idea of showing that video was to say that while all the sixers by Dhoni were very, very important, but the landmark sixer was the one which won the World Cup battle in 2011 with Sri Lanka. Somewhat similar thing will be for landmark publications. What is the criteria for landmark publication? Is it an article published in a journal with a high impact factor? Is it the journal citation, the article citation number? But I personally feel, and I think TSC talked about it, it's primarily the articles where they're published in a small journal or a big journal, where they're cited more or not, but whether it has changed the algorithm in the way we manage small bowel disease. And that has been the main criteria for my selecting these 10 articles for almost 1 lakh articles which are available on small bowel evaluation. Now, I must also tell you that these are the 2 architects of some of the landmark studies which I'll talk about, and I had the pleasure of hosting Dr. Paul Swain from UK, and Dr. Yamamoto from Japan in Kolkata some years back. So what was the evaluation of small bowel till 2000? You will all agree, this is maybe looking a little simplified, but it was primarily barium, which could be barium will follow through, or barium enteroclysis, or barium enterography, and CT scan. And we basically depended on these along with some of the other investigations to decide the intervention, which could be either a medical intervention or a surgical intervention. This was broadly the algorithm which we are following till 2000. And then came capsule endoscopy. The idea of capsule endoscopy was primarily with Paul Swain, and he showed in these two brief reports published almost simultaneously in 2000 in GI endoscopy in Nature, that how to miniaturize a camera, how to develop a small chip which can be put in the camera. And he also showed in 10 normal human beings how the pictures look like. And this led to what I call as first landmark paper. This was an animal study published in 2000 in Gastroenterology by Paul Swain and his group. He looked at canine small bowel, 9 of them, put colored beads inside the bowel. Then he performed capsule endoscopy in 23 times, and 9 had push enteroscope, and these were blinded technique. This is how the image, how the capsule looked like at that time. This is 2000. These are the canine small bowel images. You can see that not only the capsule has picked up these beads, but has also picked up some finding like worm inside. And this started our using the capsule endoscopy. They also showed that compared to push enteroscopy, which had a sensitivity of 37%, capsule endoscopy had a sensitivity of 64%, and therefore capsule was definitely better than push enteroscopy. I consider this as a landmark article because this has paved the way for development of capsule endoscopy in next 20 years. And today we have excellent images by the more modern capsule endoscopy, and it has become one of the important modality for looking and evaluating the GI bleed from the midgut. We can also diagnose Crohn's disease based on capsule endoscopy by looking at some of these features like fissuring, aphthous ulcers, serpiginous ulcers, multiplicity of the ulcers, cobblestoning, and presence of strictures. So I think this was no doubt a landmark article leading to change in the algorithm. And how did the algorithm change? So from 2001 to 2003, very rapidly after the introduction of capsule endoscopy, we had capsule endoscopy and CT scan becoming important investigations, whether these patients with GI bleed or inflammatory disorders. And then the interventions were either medical or surgical, as was earlier. Now let's move on to the second landmark paper. And second landmark paper is on double balloon enteroscope. And this is Yamamoto from Japan. This is an article published in GI Endoscopy in 2001, 1 year later than the capsule endoscopy. A few points to check. This article had only 4 cases. And look at the date of publication. It took almost 1 year to get this important article published from this Japanese individual in a US American journal. So this was what was the first double balloon enteroscopy prepared on an Olympus endoscope, which he subsequently moved onto Fusion system. Now, this is the first human double balloon enteroscopy done by Yamamoto. And interestingly, in the first case itself, he could reach and cross the ileocecal junction and enter the cecum. And he found in this patient with GI bleed a Meckel's diverticulum with a small ulcer by the side of the Meckel's diverticulum, which was responsible for the bleeding. So I think this paved the way to double balloon enteroscopy being used extensively in the next 20 years, both from the oral route and from the anal route, and giving us not only excellent pictures of the small bowel, but also allowing us to perform various types of procedures. So I think these videos may not be running, but then we know that this also showed us that a small bowel AV malformation could be controlled with APC and polypectomies could be done. Now this changed the algorithm. So in 2004 to 2007, with capsule, we had double balloon enteroscopy, and one was to decide whether to do capsule or double balloon enteroscopy or do a capsule followed by double balloon enteroscopy in the algorithm of small bowel evaluation. Of course, CT scan still continue to be important investigation. And this time, with the advent of double balloon enteroscopy in the intervention, endoscopic intervention was added besides medical and surgical intervention. So double balloon enteroscopy changed both the diagnostic approach and the therapeutic approach for the small bowel evaluation. Now, my third landmark paper is related to single balloon enteroscopy. And this came in 2008 from Suzikawa, again from Japan. We don't talk much about him in our day-to-day academics, but this was also a landmark study. And this I have put as a third landmark study for small bowel evaluation. So the change was, as we all know, that rather than having two balloons, there was only one balloon on the overtube, and the balloon on the scope was dispersed with. These endoscopes were 200 centimeter length to start with, 9.2 millimeter in diameter, 2.8 millimeter channel, 140 centimeter overtube, and the overtube diameter was 13.2 millimeter. And in this landmark study published in Endoscopy, they did 78 examinations through the oral or anal route, and these were the findings: ulcers, enteropathy, jejunal adenocarcinoma, lymphoma, and angiodysplasia. And these were how the procedure were done. So I think this was a very important step because it was considered that it was technically easier to perform a small bowel endoscopy with a single balloon rather than double balloon. And a lot of us then switched over from double balloon to single balloon. And in this aspect, I think this was a landmark article. Now, while endoscopists were developing this is how single balloon pictures can give a very beautiful demonstration of various lesions of the small bowel. So while we were developing in the terms of endoscopy, radiologists were not far behind. In our training period, we were primarily depending on enterography and enteroclysis of barium type. We were not used to CT or MR enteroclysis or enterography. And when we required imaging by CT, it was conventional CT scan. There was a small article published in Radiology in 2009, which evaluated CT and small bowel Crohn's disease by CT enterography, MR enterography, and small bowel studies. This was a study conducted on 31 patients only with either established Crohn's disease or suspected Crohn's disease. And they looked at the performance of 3 types of enterography. So there was when you look at the mucosal lesions and you look at area under curve, the 3 technologies were comparable. But if you look at finally look at MR enterography, area under curve was much better, 0.991, compared to somewhat inferior for the other 2 technology. More important than that, compared to barium, these gave almost 100% sensitivity for extramural lesion, whereas for the mural or intramural lesions, the sensitivity was in the tune of 83 to 89%. And of these 2, MR enterography, because of absence of radiation, became more and more popular. So this is one of the image from that study, which showed the CT enterography showing the Crohn's disease in the terminal ileum, MR enterography, and the barium, which almost missed this lesion. So we now use MR enterography to a great extent for evaluation of mural and extramural diseases. So with the development of small bowel evaluation by either single balloon or by MR enteroclysis, the algorithm again changed between 2008 to 2011. And to capsule, we had now double balloon and single balloon enteroscopy, and CT scan more or less was replaced by CT and MR enteroclysis or enterography because of the advantage which I talked about. Of course, the interventions could be medical, surgical, or at single or double balloons. So now another development which took place in the imaging was the advent of CT angiography. Before the CT angiography was done, often when there is an obscure GI bleed of a significant severity, the radiologist will go in and do first a flush aortography. That means you're putting a contrast in the aorta itself and trying to look at where, in which territory, superior mesenteric, inferior mesenteric, or celiac, the lesion is. And if you don't find, which you may not find in all the cases by flush aortography, then one may have to do either a superior mesenteric angiography, followed by a celiac trunk angiography, and then followed by inferior mesenteric angiography. So this meant a lot of radiation to the patient and a lot of contrast utilization. But this study, which was published in World Journal of Gastroenterology in 2010 from a Chinese group, changed the approach. This I consider as landmark article number 5 in small bowel evaluation. They said 9 studies, mostly prospective, some retrospective also, which compared CT angiography primarily with conventional angiography. As I said, 9 studies, 198 patients only that looked at CT angiography in acute GI bleed. And look at the sensitivity, 89%, specificity, 85%. In fact, 92% was the pooled specificity, and area on the curve was 0.9297. More importantly, there was no heterogeneity of data in 9. So all the 9 studies consistently showed that CT angiography is a very good modality before you do a conventional angiography. This is one of the images from that article. It shows the extravasation of contrast in the small bowel, which subsequently was proved to be an AV malformation on a selective angiography. This study also showed that as compared to conventional angiography, CT angiography can pick up smaller amount of blade at the rate of 0.3 ml per minute as compared to 0.5 to 1 ml with conventional angiography. So this again changed the algorithm for small bowel evaluation. And this is what we've been following from 2012 to 2019, that we had capsules and balloons, we had CTMR enteroclysis, but we added CT angiography before subjecting our patients to conventional angiography. And then interventions could be either at balloon, it can be at angiography, it could be medical or surgical. So I think this is the algorithm, though simplified, which we have been working for the last 7 or 8 years. And then in the last 1 year, we've been talking about novel motorized spiral enteroscopy. And we all know about it. We have been talking about in various conferences. This is a method in which by a specialized enteroscope, you can push the foot pedal. And this, if you position your scope properly, will propel by itself and can reach very fast, very long areas in the small intestine. Now, this is the first video. I don't know whether it will run or not. Yes, it is running. This is the first demonstration of human novel motorized spirus enteroscopy by Dr. Neuhaus from Germany. And you see an AV malformation in this patient. And this also video, which is available on the YouTube, showed that if you place your endoscope properly, it will progress very fast to look at the small bowel. So you can see how Dr. Neuhaus is positioning his scope, just pushing the pedal, and then it is moving forward. Now, this was the concept which led to another landmark paper, and put this as a 6th landmark paper, which had 164 patients were evaluated for suspected small bowel. They excluded about 32 patients, did spiral enteroscopy motorized in 132 individuals. And this is the result. They also showed that they can also do therapeutic maneuvers. And this is an EMR performed in patients with multiple polyp due to Peutz-Jeghers syndrome. So coming back to the results, 140 procedures performed in 132 individuals. Overall diagnostic yield was 74.2%. 68.2% of the procedures included some form of endotherapy. Technical success was achieved in 97%. Depth of maximum insertion was 450 centimeters. Median insertion time to depth of maximum insertion was 25 minutes. And they could reach cecum in 10.6% of their patients by antegrade route itself. Only 2 patients had major adverse effect in the form of a delayed perforation or a bleeding from Mallory-Weiss tear. So this study is the first study on a significant number of patients which has evaluated the motorized spirus enteroscopy. I would call this study, which is published only last month from AIG group, as 7th landmark articles, because it is good to have inventors showing their data. But I think if it's going to be validated in another center, and that's what AIG group has done in this article, which is published last month, they validated the data of Dr. Neuhaus by performing this procedure in 61 individuals with either obscure GI bleed, unexplained abdominal pain, chronic diarrhea, and they showed almost similar results at Dr. Neuhaus. Technical success, 93% in integrate, 100% in retrograde. They also showed depth of maximum insertion, total enteroscopy 61%, adverse effect in none, diagnostic yield 65%, and therapeutic intervention in 24%. Now, Mohan came to our center last year, and he performed with us one case, which I will show you there. because Mohan is the main lead author in this article. This is a capsule endoscopy, shows a GI bleed, and we went ahead with the power spirals to find out the source of bleeding to treat it. Coming to this article, he had inflammatory lesion in 25, either Crohn's disease, tuberculosis, or others. Retrieval was done of a capsule in 1 and stricture dilatation in 3. Vascular lesions in 10, angiectasia in 8, which were treated by APC or hemoclip. One such case is being shown here. You'll see the clip being demonstrated. Mass lesions in 4, growth subepithelial lesions of polyposis syndrome like GIST, NET, Peutz-Jeghers, and in 1 there was a scariasis. They also showed polypectomy successful in 1. So this patient, you can see that the clip is being applied to a vascular lesion which we found in the small bowel. And with the application of 2 clips, we could control the significant bleeding, which led to a hemoglobin value of 3 gram% in this patient. So I think this revalidates the study by Dr. Newhouse and can be considered as a landmark study. With these 2 studies, we know that motorized spirals enteroscopy is here to stay because it is a simplified procedure, requires standard, sorry for the spelling mistake, endoscopy skills, eliminates the overtube, integrates the spiral, reduces the complication, achieves good depth of insertion, and retains super speed and control. So in 2020, what is our algorithm for small bowel evaluation? We have capsules, we have 2 balloon enteroscopy, and now we have novel motorized spirals enteroscopy. Of course, we have enteroclysis, CT angiography, and interventions, which can be done at balloon, at spirals enteroscopy, medically, surgically, or by angioembolizations. So that completes my number 7. So number 8 article is meta-analysis of various device-assisted enteroscopy. Now, this article is published again this year only in World Journal of Meta-Analysis. It's a meta-analysis which has compared various device-assisted enteroscopy, double balloon, single balloon, and spirals enteroscopy to look for diagnostic yield and secondary outcomes in the form of therapeutic yield, total enteroscopy examination time, and so on. So they looked at 384 articles, but ultimately analyzed 11 articles. So this is a summary of these 11 articles. In 1, single balloon was compared with spirals enteroscope. In 6, double balloon was compared with spirals enteroscope. And in 4, double balloon was compared with single balloon enteroscopy. Now let's look at the results. Now, the single study showed the spirals enteroscopy was better than single balloon. Look at the diagnostic yield and the therapeutic yield, but only 1 study. Now, in the 6th study, which compared double balloon with spirals enteroscopy, the odds ratio for they were almost comparable, and the odds ratio for diagnostic purpose was 1.1, and for therapeutic purpose was also 1.1. When you look at these 4 studies which compared double balloon with single balloon, again they were comparable with the OR, odds ratio for diagnostic of 0.85 and therapeutic of 1.71. So they also look at the secondary outcome. And they found when you compared single balloon with double balloon, the total enteroscopy examination time, time to maximum insertion, and depth of maximum insertion were all similar. When you compare double balloon with spirals enteroscopy, double balloon had better DMI, depth of insertion, but required longer examination time to achieve that. So they concluded that double balloon and single balloon are equal. Double balloon and spirals enteroscopy, equal yield, but spirals enteroscopy is faster, but less depth of insertion. And from single study, they could not compare single balloon with spirals enteroscopy. Now, of course, we require comparison of the other devices with motorized spirals, and I'm sure these articles we'll be seeing very soon. Now, I'm very reluctant to show this as my 9th article, but I thought when I went to the search on the Google to look at landmark articles on small bowel endoscopy, to my surprise, I found one of our own articles being written as a landmark articles. And I thought with reluctance to share just one information from this article. We have published a number of articles on capsule endoscopy, but this is what possibly converted this into landmark articles. That before our study, people will avoid doing capsule endoscopy in patients with ongoing bleed, saying that the pickup rate is poorer, all you will see is blood. But what we demonstrated in this particular study, though this was only with 385 patients, initial patients of ours, that if you do an capsule endoscopy evaluation while the patient has having ongoing bleed, after doing a bowel preparation, your pickup rate is 89% for a definite lesion. as compared to 58% if the bleeding has stopped, and the bleeding has stopped for more than 48 hours. And of course, in anemia patient with with occult blood test positive, the pickup rate is 52%. So what we concluded from this study for the first time is that hit while it is hot. Don't wait for the bleeding to stop if you have to achieve maximum information from a capsule endoscopy. And these were some of the lesions which we showed: AV malformation, NSAID-induced ulcers, polyps, tumors, hookworms, and hemangiomas. Now, I'll just take 3 minutes more if I have the time. So I have shown you by the 9 articles which I have shown that how the algorithm for small evaluation has changed with these landmark studies. So all these had important impact on the changing algorithm. To recapitulate, small evaluation till 2000, what barium and CT scan. Then we had capsule endoscopy, which was almost replacing the barium, and capsule and CT was used between 2001 and 2003. From 2004 to 7, double balloon enteroscopy was added to capsule, either as an alternative or as an additive modality. From 2008 to 11, we had single balloon enteroscope, which was added, and CT scan was replaced by CTMR enteroclysis and enterography. And we had possibility of doing an intervention at balloon enteroscopy. Between 2012 and 19, we are increasingly using CT angiography. I don't remember any of our patients has gone for a normal angiography without being wheeled through the CT scan room to do a CT angiography. And in 2020, we have now spirus enteroscopy to be added to our armamentarium. So last 1 or 2 minutes, what's the future? I do not have the crystal ball to talk about the future, but I think it's worth spending a minute or two that what will be in 2025. We are likely to have more articles on MR diffusion weighted imaging. We may hear more about therapeutic capsules and about artificial intelligence, and maybe about robotic enteroscopy. Now, just last, and I thought TSC has given me liberty of 10 articles, so I'll just touch upon one article on artificial intelligence. Capsule endoscopy, we all know, is labor oriented. Even if you use single view to quadruple view to dual view to mosaic view, you need to spend quite a bit of time to look at these images. So artificial intelligence, particularly deep learning by convoluted neural network, is taking a big leap in this, though I cannot call these 3 one-slide articles which I'm showing you, but I have purposefully numbered them as 10A, 10B, and 10C, that by using artificial intelligence and a convoluted neural network, you fed a lot of training images to the computer, like in this particular study, 2,200. And then you test rest of the images to look at the validity. So in this particular study, for small bowel angioectasia, the sensitivity was 98%, specificity 98%. Similar study has been done for small bowel ulcers. And again, by feeding a large number of images, the sensitivity and specificity for automatic detection of ulcers has been 88 to 90%. And my final slide is on identification of all types of small bowel diseases and normal variant by capsule endoscopy, again published in gastroenterology a few months back. Almost 5,000 patients, full video, 1,58,000 images were fed, and the sensitivity and specificity was very high compared to conventional imaging. And best part was the time for evaluation was 5.9 minutes compared to 96 minutes by conventional method. So I think while I cannot really call them as yet landmark articles, but they are likely to lead to another landmark article. Thank you very much for kind attention.
Thanks, Mahesh, for selecting and making a story out of such a landmark papers. And I think I'll, without stepping onto the other, I think I'll pass on the mic to Dr. Chandrasekhar, who can go into this, because I believe the question answers will be at the end of the session. So we'll wait till then. Over to TSC.
Thank you, Ajay. On small instruction, while a speaker is giving a talk, I request other moderators and commenters will keep it muted. And Ajay, thank you very much for moderating the session and introducing speaker, Dr. Mahesh. Mahesh has done a wonderful job, the landmark publication into a story. This is, I liked it very much. Number two, this is what the serve the purpose. I think when Mahesh was asked to give this talk, he was asking why not I just give a simple lecture. No, the kind of impact of these papers, we need to know that this is what exercise you wanted, and you really caught the message what I wanted to convey through you. I'm very glad. I'm thankful to both Mahesh and the Ajay. As Ajay said, we'll take up the question later. Now I have the pleasure to introduce Dr.
3:45 itself. I'm here only.
Mohan Prasad. Mohan,
Sure.
Mohan, am I audible, Mohan? Mohan, you have to unmute. Mohan
Unmuted.
Prasad.
Can you hear me, Chandru? Yes.
Mohan, welcome to this webinar series. And I didn't see you in the introductory this one.
I was there from 3:45. I was there.
Yeah, I'm glad. Dr. Mohan Prasad has been the president of Indian Society of Gastroenterology, and he has been the president of Endoscopy Society of India. And he is also a keen interest in small bowel, both capsule endoscopy initiated in this part of the country. And he loves therapeutic endoscopy work, and he's a great speaker also. And to have him here to introduce Dr. Govind Makharia is a pleasure to having you, Mohan. So I request you take over the proceedings, introducing the speaker and the topic.
Thank you, Chandru. Can I just request to share the screen, please? I just want to put up 4 slides. I'll promise you I'll take only 3 minutes. So can you please permit me to share my screen?
And you will be introducing the speaker and topic and
Yes.
this one.
Sure.
Okay.
Can you please? Yeah. Okay. I got it. Okay. So I just want to start with the hero. My salutations to the hero, to Dr. TSC, a man who could make our Prime Minister smile. See the smile on his face. Very rarely you can see our PM smile anytime. So he is a magician who can transform people and their moods. He's phenomenal. So my salutations to TSC and the whole group at MedIndia for such lovely academic programs. So he's a leader par excellence. So salutations. And to introduce a speaker, Dr. Govind Makharia is a professor of the Department of Gastroenterology, Human Nutrition at AIIMS, New Delhi. He doesn't require any introduction, but I thought the custom requests me to do it. So I'll just go ahead. He's an alumnus of the PGIM at Chandigarh. He has trained 80 fellows in GI, 9 PhD students, published 246 articles in index journals, 40 chapters, edited a book on celiac disease. He is presently the Secretary General of ISG, co-chair of Clinical Research Committee, World Gastroenterology Organization, council member of APAG, coordinator DBT Consortium on celiac disease, co-inventor of a device for fecal incontinence and also for liver biopsy. He's received many awards, a BMJ Southeast Asia Research Paper Award for 2016, ISG Om Prakash Memorial Award, ISG Zydus Oration, SR Nayak Memorial Oration, AIIMS Excellence Awards. And he's an inventor of the Young Clinician Program for Indian Society of Gastroenterology. With TSC, was also a past president. So you just appreciate how beautifully it has gone on over a period of years. So before I move on to requesting the speaker to speak, I thought there are landmark publications which made strides and have completely revolutionized the thinking process in the field of medicine, in the field of gastroenterology. And since the next speaker is going to be speaking on the Crohn's disease and diseases, I thought I should put up this paper, which Dr. Crohn, the Burrell B. Crohn, presented. This was the first publication on regional ileitis, which appeared in JAMA way back. So, and this revolutionized the thought process on Crohn's disease. And now we see that in South, the Crohn's is tremendously increasing when compared to UC, which is stable. We have a 10-year data at VGM, which we're going to publish. So the Crohn's is on the rise. The next one, already Mahesh spoke about this, but I thought this is the landmark paper which Paul Swain and Gabriel Litton published on capsule endoscopy, which paved the way for introduction here. This appeared in 2002, and then we could launch it in India along with Dr. Nageshwar Reddy in AIG. We both launched the same week, and then now we can diagnose more and more of small bowel disease. And again, this novel motorized power spiral, which Mahesh has already spoken. This is the first paper published by Neuhaus, which changed the whole scenario. Now this is a retrograde enteroscopy that we are doing using motorized power spiral. That was a stricture because of Crohn's disease, and there was a retained capsule which we could take out. So with this, I should thank every one of you for giving me this opportunity. I'll stop sharing my slides and over to Govind Makharia for his beautiful presentation on diseases in small bowel disease and the landmark papers. Thank you, Chandru, and thanks to the team MedIndia.
Unmute, Govind. Just unmute.
Okay.
Unmute.
Am I audible now?
Yeah, you are audible now.
Thank you very much, everyone. Thank you, Dr. Chandrasekhar, for your kind invite. Thank you, Dr. Vijay Mohan Prasad, for kind introduction. And we just heard a wonderful talk on GI endoscopy, landmark paper by Dr. Mahesh Goenka. This is a wonderful forum Dr. Chandrasekhar had created, that remembering those papers which made differences in understanding of various diseases. So coming to, I was asked to talk about landmark papers in celiac disease and Crohn's disease. So let's take on. First, coming to celiac disease. Celiac disease, we know, has been a disease known for a long time. In 1900th century, and even before that, this was described as malnutrition and growth retardation, and described by Samuel Gee in England and Christian Herter in US. And this disease was known as the Gee-Herter disease, and the very high mortality in early part of last century. Then came something, and at that point of time, the treatment was some dietary modification, and the treatment was more of an oyster diet, be it, sorry, the screen may be visible by this video. So by oyster diet or Franconis diet or even carbohydrate and fat restriction, people believed that the celiac disease is caused by diet, and therefore some kind of dietary restriction will lead to improvement in disease. Until 41, these were the diet. And that point of time, we had other diet, which was mainly banana diet, that all those patients who had these symptoms, give them bananas. That was the diet that point of time. Something unique happened, and this very humble a pediatrician in Netherlands, his name is Willem Karel Dick. So I will share some story about discovery of celiac disease. One of his patient's mother told him that my child is good if I don't give him wheat or bread. And he took this point from mother's narration about her child's disease, and they started questioning subsequent patients. And over 10 years, 31 to 41, he had 5 patients, just 5 patients. And in these 5 patients, he used to ask symptoms, modulate their diet, sometimes stop wheat and look at their symptoms, sometimes give them wheat and look at their symptoms. And over 10 years, he convinced himself that giving wheat leads to symptoms in these subjects. And further on, as he was still trying to convince himself that wheat is the cause for celiac disease, in 1945, at the end of World War II, there was a winter of starvation. There were no food available in Holland, and people were living only on fruits and vegetables. At this point of time, all these patients with celiac disease, so-called celiac disease, got better. And once the help came, then bread were airdropped from airdropped in Holland, and these children who improved, they again worsened. And that was icing on the cake, that he had convinced himself that wheat is the reason for celiac disease, and this observation further convinced him that wheat indeed is the cause of celiac disease. And he concluded that wheat is likely culprit. So wheat, wheat has both starch and protein and fibers. So which component of wheat is responsible for celiac disease? And again, very inspiring story. He had 5 patients. Patient number 5, she was a young girl, and she used to have violent symptoms of nausea, vomiting, pain, 3 to 6 hours after once she would eat something made from wheat. And then what Dr. Karel Dick did, that sometime he restricted the patient, giving only wheat starch. There was no reaction. They gave him wheat protein, there was a reaction. They gave him wheat fibers, there was no reaction. And when they gave him rice flour, there was no reaction. By this experiment on one patient, he convinced that wheat protein is indeed the component in the wheat which leads to these symptoms. And therefore, he wrote his thesis, which was published in 1950, and he concluded 5 statements. His conclusion was the symptoms of anorexia and corrected stool disappear with weight gain and growth when patient is given wheat-free diet. Patient gets better if you don't give him wheat. If you give him wheat, the symptoms gets worse, and therefore he concluded wheat flour and wheat protein is the reason for celiac disease. And this was a remarkable thesis at that point of time. Again, of wheat protein, wheat protein has albumin, globulin, and other components. So which component of wheat is responsible for celiac disease? And then what they found, that the wheat has 2 components, gliadin and glutenins. So of these, majority are, almost 43% of amino acids are glutamine. So what he and his team did, that they deaminated gliadin by treatment with hydrochloric acid, and therefore abolishing the effect of glutamine. And it was found that after abolishing this activity, the symptoms did not appear. Therefore, he further confirmed that wheat is the cause, wheat protein is the cause, and even the wheat protein, gliadin, is the cause of celiac disease. And this was published, the other paper at that point of time in 1953, confirming that gliadin is indeed the cause for celiac disease. And this was further confirmed by many other papers during that point of time. And after this was known that wheat, if you stop wheat, the patient gets better. The mortality was earlier quite high, but later the death was uncommon because these children were not given wheat diet. Therefore, this is one disease that we knew treatment of this disease, like celiac disease, wheat stop is the treatment. We did not know a word about how it occurs. We did not know a word about how to diagnose them. So this is one disease where we knew the treatment before we knew anything else about the disease. And this is the, in my opinion, landmark paper. And I would believe that this is one of the most noble work can ever appear, just because of observation and a very dedicated clinician, by observing 5 patients over 10 years and looking at their improvement, and by experimentation, you could confirm that celiac is caused by a dietary factor, that is wheat. We have so many autoimmune diseases, type 1 diabetes, systemic lupus, rheumatoid arthritis. Do we know that diet is maybe the cause in some of them? And therefore, I believe this is the landmark paper for celiac disease. Now move on. What happened next in the story, that once we have a celiac, small intestine, and leading to malabsorption. But how do we look at the small intestine? And again, very inspiring story from this doctor who was a hematologist, and he was working with American Army at Walter Reed Hospital, which was a military hospital. And William Holmes crossed by. He was a very interesting guy, and he wanted to work in Korea. in 50s, and he worked in mobile military camp. And there he found in Korea a lot of soldiers, Korean soldiers, they had sprue. So he wanted to work on sprue. And again, his next posting was in Puerto Rico, and there he wanted to look at small intestine, and then he devised his Crosby capsule. This Crosby capsule, I think we have seen this as a specimen lying with some of the older institutions like PGI. We had this capsule, one piece lying there as a specimen, where the patient, you have a capsule which has a biting system, patient will swallow, and there's a long string. The capsule will go by peristalsis to small intestine. As you reach small intestine, and you put a trigger, and the biopsy comes. And this led to view of small intestine, non-surgical, looking at biopsy from intestinal mucosa and looking at mucosal changes. So this was published in 1957, and I believe this is again one of the landmark in celiac disease and small intestinal mucosal tissue tissue biopsy. And later, other group published a data of almost 4,000 per oral biopsies in children using Crosby capsule. I believe this is a landmark paper in celiac disease. And since 80s, the endoscopy emerged, and therefore Crosby capsule went out of use. Now, so that point of time, I think when we were training, the celiac disease was diagnosed was extremely difficult, and there were no blood tests available. And the biopsy required 3 sequential biopsy, that you do biopsy to demonstrate villus abnormality. Once patient is a gluten-containing diet, then you stop wheat, patient improves, you confirm that histology is improved. Again, you re-challenge and take a repeat biopsy. And taking 3 biopsy and changes in small intestine will confirm celiac disease diagnosis. But this was so hard to do 3 biopsies in a given patient. And therefore, celiac disease remained very, very uncommon at that point of time. So in 1990s, a group of pediatricians, they joined hands together on the behalf of European Society of Gastroenterology, Hepatology and Nutrition. And they say, no, we can make diagnosis even without 3 biopsies. And they published an article which is a revised criteria for diagnosis of celiac disease. And the criteria were that patients have symptoms like diarrhea, anemia, short stature. There should be villus abnormalities by doing endoscopy and taking biopsy from there. There's a villus abnormalities, and give them gluten-free food. And if there's an unequivocal response to gluten-free food, then this is celiac disease. And this was again remarkable paper. Why it was a remarkable paper? Because from 3 biopsy to just 1 biopsy, you will change in the practice of celiac disease, and it led to increase in number of diagnoses of celiac disease all over Europe and America. And I believe this is the 3rd landmark paper which changed the diagnostic criteria for celiac disease. That point of time, while these were being the immune system of celiac disease was evolving, what happens in histology was not well known, except for the villus atrophy. If it occurs, this is the diagnostic criteria for celiac disease. Therefore, only those who have advanced disease will be diagnosed, and those who have minor lesions in histology will not be diagnosed. And therefore, this gentleman called Michael N. Mars, he used to work at Oxford in UK. So he started working on celiac disease histology, and he knew that celiac changes occurs in a sequential form. There are steps where disease histology progresses, and therefore he defined by his experiments that the disease had 3 phases. The first, there's infiltration of intraepithelial lymphocytes. Second, there's a hyperplasia of crypts, and then there is a villus atrophy, that's called destructive phase. And this led to a birth of histological classification for evaluating the severity of villus abnormality in patients with celiac disease, which till now, this is published in 1990, but this is a gold standard criteria for using histological classification in patients with celiac disease. Even today, both clinical research and patient care all over the world, we use Mars criteria for histological grading of celiac disease. Very interestingly, once Mars was, Michael Mars was working on celiac disease, he was told that there's a disease called tropical sprue, and there's a wonderful work is being held in CMC Vellore, and he writes in his seminal paper a paragraph about his experience of going to Dr. V.I. Mathan. And he also published the picture of courtyard of CMC Vellore in his original publication. And I copied this picture from that publication. And what he writes, that shortly after that work was published, I was arranged for me to work with Professor V.I. Mathan, who also, like myself, had recently been a research fellow in Bob Donaldson's unit at Boston City. I was interested in extending the same type of histological features in tropical sprue. Therefore, I felt so proud. I didn't know this. I felt so proud that one of our institution, say CMC Vellore, had been and at the top that point of time, say about 30-40 years back. It was the top of luminal gastroenterology and doing remarkable contribution, led to remarkable contribution to knowledge of small intestine. And all V.I. Mathan and his whole of his team were involved in that. So I believe this is the fourth paper, which is again, not third, this is the fourth paper which has changed practice.
It's 5 o'clock.
So coming to another concept, I wouldn't say paper, but the concept. The concept was that before that point of time, say in 80s and 90s, or so basically till 80s, the diagnosis was based upon only histology. Now we didn't have any blood test. People were knowing that celiac disease it occurs because of gluten protein, but how the gluten leads to destruction of small intestinal mucosa. And there were two theories were going on that point of time. The first theory was that there's a deficiency of some enzyme which leads to incomplete indigestion or digestion of gluten, and that leads to some amount of toxic part of gluten into small intestinal mucosa, and that leads to damage. This one concept was because of deficiency of enzyme. And second question was that gluten by degradation leads to some kind of immune system activation and therefore damage to small intestinal mucosa. But this was not proved, and therefore that point of time, again from at Oxford, UK, a group led by Taylor et al. Looked at if it is immune system induced damage, there must be some immune marker in the blood, and there must be some antigen, an antibody. If there is some antigen, there must be some antibody in the blood. So what they did in an experiment, they took patients who were diagnosed with celiac disease, both adult and children, and in their blood they looked for antibodies, and for that using antigen, which is a tryptic digest fragment 3 of gluten protein, they took as antigen, and they used these three methods to find out these antibody. And what they found, both in children and adults, that the patient with celiac disease had a higher level of the antibody against gluten, which they label as an anti-gluten antibody, which became as a anti-gliadin antibody as a test later. So again, this whole concept, this paper led to, which I published that point of time into BMJ, and I believe this is again one of the landmark paper, which led further to more detection of anti-intermicelle antibody and anti-tissue transglutaminase antibody. And now we use this antibody as a diagnostic test for celiac disease. But the concept of this antibody came from this remarkable paper published in 1961. Coming to another important concept, that while the celiac disease pathogens was being evolved, then it was immune system which would lead to damage to small intestinal mucosa in response to gliadin proteins. So that time the question came that this antigen has to be presented to antigen presenting cells, and how it happens. And this was one of the important thoughts. And this paper, which came from Oslo, and which confirmed that these antigens are picked up by APCs, antigen presenting cells, those who have a HLA-DQ2. And then these molecules are presented to T cells and the T cell damages. Again, this is one of the most important steps in understanding the pathophysiology or immune pathophysiology of celiac disease. And that also led to a series of multiple other studies which later defined the whole immune pathogenesis of celiac disease. And this is also a landmark paper. Now coming to a bit more about how this has become so common. So it was an uncommon disease, occurred only in western part of Europe, and it was known only that part. And whole of the world believed that celiac disease does not occur in their own country. So over time, the celiac disease epidemiology have changed over a period of time. And how it happened? Because once we had an antibody available for testing for celiac disease, so it was easy to do a large studies in the community to find out prevalence of celiac disease. And this is the first study published by my friend Carlo Catasi in Italy, where he screened and his group screened 17,000 children, and he confirmed that 1 in 184 children had celiac disease. But still, it was only Europe, and in America, celiac disease was not known. So then something happened that a person called Alessio Fasano, he was Italian, and then he moved to US, and he started working in US hospital. He has seen a lot of patients in Italy, but no patients in America. Then he wondered why Americans don't have celiac disease. And then he started looking for, since he was already attuned to look for celiac disease, then he started seeing patients with celiac disease, and then he did a study involving almost 4,000 American children and adults both together, and he found that 1 in 131 Americans have celiac disease. And that led to evolution of celiac disease in America and then to other parts of the world. Same in our country, celiac was thought to be uncommon, only seen in children, but not as a major disease. And then we had a paper from Dr. Ajit Sood showing 1 in 310 having celiac disease. Then we have a paper from our institution showing 1% of North Indians having celiac disease. And again, people believe that celiac occurs not in the part of India, not in southern part of India. And this is a pan-India study, which was led by Dr. B.S. Ramakrishna from CMC Vellore, and we have a pan-India prevalence of 0.6%. Moreover, we wanted to know what is the global prevalence of celiac disease, and then we did a meta-analysis of all the papers, and we found that seroprevalence of celiac is 1.37, which is global, and biopsy confirmed celiac is about 0.68%. And looking at this 7.4 billion people in the world, about 40 to 60 million people worldwide have celiac disease. And this paper was published in CGH, and this came as a cover page also. And this was cited almost 40 times over last almost 2 years, and it was regarded as the best cited article in CGH. So I would say the series of papers on epidemiology are landmark paper, and most important paper which led to this was from Italy, which was the first study on epidemiology. Now still we have a difficulty in diagnosing celiac disease because it required biopsies, and taking biopsy is not easy, especially in children. So people wanted to know that can we have a non-biopsy pathway for making a diagnosis? And over time, when serology started being used in practice, a lot of confidence came because the sensitivity and specificity of anti-TB antibody is quite high, almost 95%. And it also demonstrated that if you have high titer of this antibody, anti-TB antibody, it predicts presence of villus atrophy almost 100% times. If TT is more than 10 folds, you can predict that person has villus atrophy. Therefore, you might avoid doing a biopsy. And therefore, the SPAGHAN, the European Society of Pediatric Gastroenterology, Hepatology and Nutrition, and their whole team led a criteria that if you could diagnose celiac disease, if you have TTG more than 10 folds, you have positive EMA, and you have compatible HLA-DQ2, DQ8. And later, it was further simplified If we have a TTG more than 10-fold and EMA is positive in second sample, then you can say this patient has celiac disease. Mind you, this is only for those patients who have a TTG more than 10 folds. Less than 10 folds, we cannot be sure this is celiac disease. And I believe this is a landmark criteria in celiac disease. So coming to summary of landmarks in celiac, a story of inspiration by William Carroll Dick, the way he discovered the wheat and wheat protein as a cause for celiac disease. Then sequential change in biopsies by Michael Mars. Then advent of serological test, AGA and NT-TTG and EMA subsequently. The immune pathways description from Oslo, Amsterdam and Chicago. And then we have an evolution of criteria by Spagan and changing epidemiology by Kitasi, Fasano and some of Indians. If I take a break and go to Crohn's disease, again, Crohn's disease also has a lot of stories of inspiration. Crohn's disease was known before Crohn's described, but name was not given. So how the Crohn's disease came into being? Again, this is an inspiring story, and this is which Dr. Vijay Mohan Prasad already alluded to, that Dr. Crohn was working in Mount Sinai, and he found two patients had a disease in terminal ileum and both behaved similarly. He was interested, what is this disease? Then he went to his pathologist, Dr. Paul Klemper, and he asked, because he told to Dr. Crohn's that some of other colleagues do have similar illness. And then he asked everybody to bring all the cases to him, and he reviewed all 14 biopsies, all 14 patients. Later, and all these patients were operated by a surgeon called Albert Berg, and he was the surgeon who operated all these 14 patients. Once everything was done, this paper was presented into a AGA meeting, 14 patients, and they called it the terminal ileitis, 14 patients description. One of the attendee of the conference of this annual meeting of AGA, he told that please change the name of the disease from terminal ileitis to regional ileitis, because people may get afraid. Terminal means death. Therefore, please change the name. And therefore, the name was changed to regional ileitis. So once paper was to be published, Dr. Berg, who was the master of all these patients, because he was a surgeon, but he refused to be an author to this paper. I don't want any paper. Therefore, I won't be an author here. So Crohn's published this paper, and again, interesting to know that at that point of time, the JAMA has policy that the first author will be all by alphabet. Therefore, Crohn's was the first alphabet there in this the group of 3 people. Therefore, Crohn's became the first author. He had just 2 patients in that series, but he became the first author. And therefore, this paper published in JAMA 1932 as a regional ileitis, a pathological and clinical entity. This is the first paper, and this is a landmark paper to describe a new disease. But this was still called regional ileitis. Then how the came to Crohn's disease? How? So in 1936, already since the disease was described, the people from Great Britain started calling it Crohn's disease. Same happened in Scandinavia, and same happened in US. Crohn's himself did not believe that my name will be named after this disease, but people started calling this disease, regional ileitis, as a Crohn's disease. Therefore, it became a disease which started being called as a Crohn's disease. It was not only regional ileitis, but later it was known as a pan-GI disease. And then important, once you have pan-GI disease, the important is to classify. And how to classify? Again, the remarkable work by WGO. They're first in Vienna and then into Montreal, the 2 subsequent conferences of WCOG, and they describe the classification of Crohn's disease. And I believe this is a landmark concept which gives you a whole GI tract. Now we define into calling them either based upon age, then location, and then behavior. And this is so important to understand that your therapy will depend upon what kind of disease the patient has. And this also takes you to the prognosis and the natural history of Crohn's disease. Therefore, these two papers were landmark paper were classify Crohn's disease. Now coming to the treatment, how the treatment of Crohn's disease evolved. The treatment, we knew that this was a steroid as the mainstay of treatment, and there were no other treatment available. But then there's a series of landmark papers, and the first one that was use of aminosalicylates in Crohn's disease. In 1970s and early 80s, two papers were published, one from US and one from Europe. That's called National Cooperative Crohn's Disease Study and European Cooperative Crohn's Disease Study. And both studies showed that using sulfasalazine is better compared to placebo. And therefore, at this point of time, sulfasalazine became the main seat of treatment for Crohn's disease. While sulfasalazine was being treated, but there were a lot of side effects. And again, we know this work by Ajad Khan, they found that of the sulfasalazine, 5-ASA is the active component of sulfasalazine. And this they confirmed by giving enemas of to 5 patients with ulcerative colitis of sulfasalazine, 5-ASA, and sulfaparidine. And they found that 5-ASA and sulfasalazine are effective, but pyridine is not effective. Therefore, they confirmed that 5-ASA is the active component of sulfasalazine, and this was published in Lancet. There came, therefore, the most aminosalicylates used in Crohn's was then became non-sulfasalazine derivatives, and the drug which came was Pentasa. Again, this is a remarkable study which confirmed in a study of 310 patients given over 16 weeks in active Crohn's disease that over placebo, Pentasa 4 grams has almost a 25% improvement, more improvement by using Pentasa, and therefore Pentasa became the hallmark of treatment for Crohn's disease at this point of time. And this was published by Singleton. Again, this is one of the remarkable paper. And with this Pentasa coming into picture, the gastroenterologist stopped using sulfasalazine, and therefore this becomes a landmark paper on use of aminosalicylates in Crohn's disease. But there was a twist again. What the twist? That while this paper was published in 1993, the 2 other papers were also published during that point of time, but they were negative studies. They were presented only as abstract, and they were never presented, never published as a full paper. So in 2000, in mid-2000, the Dr. Stephen Hanover, did a meta-analysis of 3 studies, 3 Pentasa studies, and what he found that there is no improvement in Crohn's disease activity index if you give to patient with Crohn's disease, and there were only improvement by 19 points or 20 points, whereas a clinically relevant improvement requires at least decrease by 50 score in Crohn's disease activity index, and it was only 20. Therefore, this paper published in 2004 led to a fall of Pentasa. Pentasa, which was the king drug to be used in Crohn's disease, by 2004, Pentasa use fell down in Crohn's disease. At the same time, during this point of time, when since early part of 2000, we started having emergence of biologics. And again, what was the policy here to look at 3 papers were published in 97, 93, 94, doing meta-analysis in 2004, and then we have a biologics. So in biologics in CD, there are a number of papers, and the 2 initial papers were by Targan, Stephen Targan and Dr. Present, and small series, but both established that biologics works in Crohn's disease. And then we had a landmark paper that's called Accent, which is a randomized controlled trial in the active Crohn's disease and also in maintenance of Crohn's disease, and that became the landmark paper. Following that, there is a series of papers using infliximab, adalimumab, and virodilumab, and many more newer drugs which became the landmark. And this whole concept was they lead to better clinical improvement, and also they lead to better mucosal healing, which is the requirement for good treatment for Crohn's disease. But everybody knew that Crohn's disease is a progressive disease, and over 5 years, a lot of patients will develop a sticking disease and fistulizing disease. Disease will so progressive from inflammatory presentation to become strictures and fistula. It means whatever treatment we give to these patients is not effective. We are not making differences to them. They still lose bowel by strictures and fistula. Therefore, the things were not very clear that why it happens. And then we had a concept of mucosal healing. This came mainly from studies done in Europe and America, where people observed that those patients who have mucosal healing, they had less recurrence of disease, they have less surgery, and they have a less hospitalization. So people understood that if there's a disease heals, the mucosa heals, the symptom will certainly disappear, but the bowel damage can also be controlled by concept of mucosal healing. Therefore, the biologics have a better mucosal healing. Therefore, biologics became the counterstone for treatment of Crohn's disease. And because biologics had a better mucosal healing. So question comes, to whom do you give to biologics? To everyone or to some patients? And again, the studies which showed that if you use biologics in children, they do better. It means if you use biologics in early, it is always good. But in whom do we use early? So many studies showed that if patient has 3 or 4 features, that this patient is likely to worsen. What are the features? Early onset disease, those who have aggressive behavior, frequent relapses, and aggressive disease, and those who have perianal disease, they were the predictors of Crohn's disease. So anybody who has these features, most likely you use biologics. And therefore, the concept came that if you have a patient who have aggressive features, so you stratify them to those patients who have likely to have a more aggressive disease, treat them early with effective therapy by using combined immunosuppression, right? Give both azathioprine and biologics early, and so on. And this is a landmark paper, which in Crohn's disease, we showed that in those patients who have a predicted course which is going to be worse, treat them early by combined immunosuppression compared to conventional therapy by step up and step down approach. And it's really showed that if you use early treatment in early combined immunosuppression, then the improvement is much better compared to conventional treatment. And again, this led to series of multiple papers further confirming that treating them aggressively from early part is probably good, but only those patients who have aggressive disease. So question is, how do you alter behavior? I just understood that most patients will progress. So if you don't treat them aggressive, the disease is going to progress from inflammatory to stricture to fistula, surgery, and everything, loss of bowel. But if you treat these patients more aggressive, by treating them more aggressive, then you might change the course and make them the disease stable. Therefore, we preserve bowel. So then the concept came, treat the target. So you fix a target and reduce the target. So there are 4 pillars of treat the target. To define the target, what is the target we want to achieve? Monitor, is the target achieved? Optimize if target not achieved, and monitor the optimized therapy for side effects. So these 4 targets were identified, and that led to question comes, if in a patient, if I treat, what do I see, which tells me that who are the patients who are high risk of relapse or disease activity. And therefore the concept came. This is a landmark concept that selecting therapeutic targets in IBD, which is called STRIDE, which I published in 2015, that you have a patient, then look at symptom resolution, monitor them every 3 to 6 months. Do endoscopy and look at mucosal healing, or do cross-sectional imaging to look at healing of the lesion, and also predict by using biomarkers. So look at everything together. Their symptom improvement, the mucosal architecture, how they don't lead to blind. I won't do colonoscopy, I won't do CT scan because they lead to radiation. Now, here that you need to monitor these patients, look at if there's a less of improvement, if there's a still active lesion, hike up the therapy. So you optimize therapy. And this is the concept which now being tested now. A lot of trials are being conceived, and we believe that this concept will probably lead to better treatment of Crohn's disease. Now coming back to our country, celiac disease, we all grew up with this paper, Crohn's conundrum in Indians. We had a strong belief Crohn's disease does not occur in our country, both North and South. Then the brave paper by Dr. Jayanti, who showed that Indian migrants in UK, they do have Crohn's disease compared to local population. And again, one more brave paper from Dr. Ganesh Pai from Manipal, where he published 25 patients with Crohn's disease in 2000. And later, now we know that country like ours, we have a large number of patients with Crohn's disease in India. And Vineet and Prasant predicted that in our country, we have almost more than 2 lakh patients with Crohn's disease. There are other landmark papers which I didn't deal today, but again, there are remarkable papers to understand the pathogenesis of celiac disease, especially genetics of celiac disease, genetics of Crohn's disease, including NOT2, understanding the immunology of Crohn's disease, microbiome, and the interplay with immune system, genes, and environment, and also many therapeutic targets. These all are remarkable and landmark papers which lead to understanding of Crohn's disease. So in summary, in Crohn's disease, the first paper by Dr. TB and Crohn describing new disease, which are never known as Crohn's disease. Again, the story of rise and fall of aminosalicylates. Then we have a series of papers on biologics, confirming the improvement in much better treatment and concept of treating aggressively, concept of stride, and again, monitor classification to classify the disease. With this, I stop here. Thank you very much for your patient listening.
That was a wonderful exposition, Govindji. Not only you brought in all the papers, landmark papers, but also you told like a story. We never thought it's like a scientific presentation. You made it so sweet. So congrats to you.
Thank you, Dr. Mohan.
I stop saying.
Govind?
Yes, please. Yes, please.
Hi. Dr. Govind, actually you have to tell two stories now. You have to tell two stories. One story about the celiac, one story about Crohn's, which is very difficult. And the one I like that your comment is why they made it terminal ileitis to regional ileitis. I was not aware of that story. I think terminal means something different. And I like the way you took it. Congratulations. It's a tough job to do that in that the 25 minutes. So I think it will go in a landmark presentation because both the speakers have done a wonderful job. And I'm very grateful to the moderators. Now we have the very eminent person in the field of gastroenterology, Dr. S.P. Misra. S.P. Misra has also been he has been the secretary of ISG ever since I knew him, and it almost for a few years. Then after that, he took over as the president of ISG and president of SGA, and he's been an active member in APA, and he has been invited to write various editorials. And a few years before, I just saw the editorial written by him in GA Bleed and other thing. So he's an eminent and a professor and HOD of gastroenterology, Motilal Nehru Medical College. I had a great opportunity to visit his center when there is a oration to be delivered. And Dr. S.P. Mishra is again the face of Indian Society of Gastroenterology. So we have that eminent personality to comment on both the papers. Now Mahesh is here. He made a nice story about the small bowel. He entered in the duodenum, safely came out of the terminal ileum. And the way he said from 2000 to 2020, that one slide will summarize the whole thing. I liked it, Mahesh, the way you made the presentation. And both the topics are open now. And Dr. S.P. Mishra, now you are on.
Well, thank you very much, Mahesh and Govind, Ajay, and Dr. Chandrasekhar. My job, you said, was very difficult. I think it's very easy because of the wonderful presentation by both the speakers. Both of them were storytellers, and they'll be very good storytellers to the grandchildren. Congratulations, Mahesh.
Thank you.
Very nice. Both of them. It went so smoothly. I was listening to it. Practically no controversies, nothing to be done. So the only thing, I'll just make it short because we're running short of time. Mahesh started off with, how we were working the small bowel earlier with barium and whatnot. And Mahesh, part of your, it was endoscopy based, but part was dealt with by Govind, the Crosby capsules and whatnot we had for that. And I was working personally with Crosby capsules. So it was very nostalgic. I went back to that era of bariums and Crosby capsules and doing whatnot for that. And then we came to the CT and MR, and now we could get CT and MR angiography, which is wonderful. And we are literally dispensed off with the putting in the dyes in the aorta and all those things. And if you don't get it, then you do a DSA, you do a super selective angiography. And a lot of therapeutic work has come in intervention radiology because of that. Then he went, one good thing was that he said that angiography, when done by CT or MR, you can pick up small beads of 0.3 ml per minute as compared to 0.5 ml per minute. So if the bead is small, probably, anyway, CT angio and MR angio is better than doing a conventional angiography. Then we moved on to the motorized spiral endoscopy. We had the spiral enteroscope earlier, which we had to screw it by hand. Mahesh?
Yes, 2007.
And then now we have got a motorized thing, which you just put a pedal and it just runs away like a car. And if you have a straight view, like you saw in the video, Dr. Newhouse, then you just enter as if you are flying through the small bowel. And it reduces the time considerably. And you can have therapeutic aspects of that too. What Mahesh basically, most interesting slide of Mahesh was his predictions. And he became a PC Sarkar sort of a thing, hearing all those things. And I've met PC Sarkar, so I thought he's PC Sarkar. Then I thought, oh, no, it's Mahesh. So AI, important things for gastroenterologists is artificial intelligence, convoluted neural networks. These are not new things. These are about 20 years old, coming into shape now. Machine learning and robotics. These four things will change the practice of gastroenterology forever. And in the next decade, I think there'll be an explosion in this field, and we should all be ready for it. So Mahesh, an excellent job done by you.
Thank you.
Coming to what Govind said, again, he was a storyteller, fantastic storyteller. And he started off with, and you said rightly, there were two things, have a common acronym, CD. Celiac disease and Crohn's disease have a common acronym. So he dealt with celiac disease as well as Crohn's disease. He started off with the history of celiac. And just imagine the most what you said was, I was fascinated by the Crosby, but the most important thing what he said, and which hit me hard, is that the treatment was before the diagnosis. And that is what I feel that medical science is. Your observations are more important than evidence-based medicine. That is what medical science was. Even now it is important. And therefore, I feel that whatever you get a single case which is important, like they got it. That is the genesis of a therapy or a disease in the future. So the treatment started earlier, and then we followed with the diagnosis. That was wonderful. And then he went to the Crosby capsules, and I was so fascinated because we were using Vim Silverman needle for Chandrasekhar. Remember Vim Silverman needle for biopsies?
Yeah. I remember both the thing, Crosby capsule and
And then the Abraham's needle and the Cope's biopsy for peritoneal biopsy.
Yeah.
They were this thick.
No,
Yeah, but we had to do it.
yeah, there was no other alternative that time.
But fortunately, complications were not that much. Then came the Jamshedi and the manganese and whatnot, and now we have got the TrueCut.
Now with comfort we have SP, with
Yes.
ultrasound guided and the liver biopsy or laparoscopy guided biopsy. We
I
don't
mean,
want to take any chance. You know?
Imagine shifting from Vim Silverman to transjugular biopsies.
Ah,
So dramatic changes there. And again, Govind, you talked about histology.
It's also sharing with radiologists.
Yes. And you know, you talked about histology. You remember we were doing oil red O stain at that time. Anybody remember that oil red O stain? Good. So it was very difficult to diagnose celiac, and this, if it is present over here, it is tropical sprue. If it is present over here, it is celiac disease. And you know, there was so much of confusion. And so now the diagnosis of celiac disease is so simple that it has led to the explosion in our country, and we diagnose celiac disease. Practically every day we get children or adults who have celiac disease.
SP will be surprised to tell you that we don't see that much of celiac here.
Yep.
We do see, but not that much as what I've seen in Chandigarh.
See, I was in Pondicherry in 1973. I joined MBBS. I wouldn't get wheat over there. No chapatis. And now in Chennai, most people are eating chapatis. So the moment you shift to wheat, probably that will get exposed.
That
I
way,
think I would like to add here, Chandru.
Not taking wheat is protective from celiac.
Yes, because the same thing happened in Second World War. You were not getting bread. So no celiac in Second World War.
In fact, I would like to share the experience of one of the gastroenterology friends of mine in the US. He says that Indians who come and settle down there, be exposed to a lot of wheat products. South Indians, they demonstrate celiac disease, whereas not the parents who don't eat so much of wheat. So I think probably the amount of exposure to wheat matters.
The more you get to wheat, you'll get the problem.
If you can add a word out here, sir.
Yes, go ahead.
So this is regarding what Dr. Mishra and Dr. Vijay Mohan Prasad said, that both South Indians have a same genetic susceptibility. In our study, which we did, pan-India study, we looked at a genetic sample from the healthy people, and we found that actually DQ2 and DQ8 haplotype frequency in the population is almost similar in all three regions. That's northern part of India, southern part of India, and northeastern part of India. So there's genetic susceptibility. But question, they're not exposed to wheat. So we know that even in those areas where rice is the main food, but now wheat is also infiltrating those areas. Even a small town of say southern part of India, wheat is reaching in the terms of bread, burgers, and everything. So therefore, we wanted to do a study. So how do we confirm that South Indians are protected? We thought those South Indians who are coming to North India, lot many are in Delhi, in the government circle. So whole RK Puram is South Indians. We thought we go to them, and those who are staying for at least one generation, the second generation, and take the samples. Look at how many of them are celiac, because they have a genetic susceptibility. Now they're exposed to wheat. So do they have a celiac disease or not? So this study we are probably going to do maybe next year.
So, Dr. Chandrasekhar, the moment you shift from idlis, idiyappams and dosais to chapatis, probably you'll get exposed to that.
No, I lived in Chandigarh for several years. No, for my MD and DM
But
If I can take it away, TSC, whenever he goes anywhere, he wants aloo parathas.
yeah, but he's not got you didn't get the cross-beak biopsy done.
No, I never had any symptom. Because you can have asymptomatic.
No, we're not talking about individuals, but the gross, the other population probably will show the susceptibility once you shift to wheat. And I told you, in 1973, wheat was not available at all.
Once Dr. S.P. Mishra is done, we have a lot of questions to Mahesh and Govind.
Okay, go ahead with questions. I'm done.
Okay, right.
Okay.
Mahesh, the first question is,
Yes, sure.
occult GI bleed, small intestinal bleed. A question from the interior of Tamil Nadu, Kumbakonam. All tests negative. The effort for capsule, that's also negative.
Oh, now you're getting.
Blood. He had 3 episodes and he had multiple blood transfusions need to be done. Hematological workup normal. So what to do now?
See, if there are studies on this viewpoint that if there is a iron deficiency anemia, particularly in elderly, capsule endoscopy is a very important investigation. It has been shown beyond doubt that iron deficiency anemia. Now, the pickup rate will be higher when there is occult blood test positive as compared to iron deficiency anemia without occult blood test positive. That's the first point. Second, it has been found in most of the studies that those in which capsule endoscopy is negative in patients with iron deficiency anemias, these patients do well during the follow-up. Some of the people have done second capsule endoscopy on them, and some additional cause has been found on second capsule endoscopy, but we know the cost involved in this. So this is a very unusual situation which you are talking about, that the patient has iron deficiency anemia, capsule is negative and yet requiring blood transfusion. I think we need to investigate whether it's all GI blood loss or there's some bone marrow problem in these patients. I think further investigation is required. Otherwise, the literature shows that these patients who have capsule endoscopy negative, at least 2 times, they do well and they do not require further investigations.
And hematological investigations?
Yes, that's what I said, that you should do hematological and bone marrow investigation in these patients rather than thinking that everything is because of GI loss.
Mahesh, is Ajay there?
Yes,
Yeah,
very much.
Ajay, actually somebody has pointed question to you.
So Ajay, I thought was a relaxed man today. No questions
why
for him.
question?
Oh, why? Because you introduced the.
No, this is Chandrasekhar is playing mischief.
I will address to both of them, Mahesh and.
No, let Ajay answer.
The question is, I refer it for capsule endoscopy. Again, upper GI endoscopy was repeated. What is the justification?
I'm sorry, I could not hear in between. There's something
So
wrong.
the question
for capsule endoscopy, already upper GI endoscopy done negative.
Yes.
Is there any point in repeating upper GI endoscopy? Is there any data available?
Yes, there is a significant data available. See, I know that when the patient is referred from a peripheral doctor for an obscure GI bleed, and when you are already upper GI and lower GI endoscopy is done, the previous people should not take it as a matter of offense, because there is a clear data that there are almost 13% increased yield after you repeat an upper GI endoscopy. And these things,
I think that's a very good message we should pass on to.
I think if I can add there to what Ajay said, there are some lesions. In fact, sometimes you repeat your own endoscopy because you made an endoscopy when the patient is actively bleeding and the lesion may be missed. And there are 3 or 4 lesions which are known to have a false negative initial endoscopy, and that includes Cameron's ulcer in a hiatus pouch. It includes a Deulefoy's lesion. It includes a small ulcer in the fornix or the posterior wall of the D1. And it includes highest point of the lesser culture ulcers. These are likely to be missed on the endoscopy, particularly done in a compromised situation. So as Ajay rightly said, you are fully justified in repeating an endoscopy.
And Chandrasekhar, any vascular lesions, if there's such blood, it will collapse. And once you transfuse the patient, then you see the vascular lesions.
So you would like to concentrate on blind areas.
Yes.
Okay.
And also, Chandru, I'd like to add on a point here. I did an endoscopy where I missed an ulcer. And then capsule picked it up because we went back and saw the video recording because we store all the videos. There was froth over the ulcer in the antrum on the greater curvature. When endoscopy was done, it was not washed properly. So it just missed out. So that was a non-steroidal drug-induced ulcer.
Now, is it a big ulcer or a small one?
Small ulcer, about 3 millimeters.
Question to Mahesh: can spiral the enteroscope replace balloon in future?
I think there's a potential. It's a bit too early. We have only 2 detailed case series, no head-to-head trial. But I think it has a potential to replace. And the best part of the Spirus is it doesn't require, an average endoscopist can possibly do it. So I think compared to double balloon, which requires more expertise, more steep learning curve, Spirus enteroscopy does not have a steep learning curve. I see in the next 5 years, when you call me back after 5 years for another presentation, I will tell you that it has already replaced.
Before that, you will have multiple presentations here.
Mahesh, the problem is the depth of the insertion.
I think what we have been shown in the study by Dr. Newhouse as well as Mohan Ramchandani is 10 to 30% of the time they could do with a single insertion complete endoscopy. So I think it's an evolving field, too early days, but I'm sure it's a thing to look towards for the future.
Okay, very pointed question, Nagesh.
Yes, I like to just interject here. You see, spirus look very impressive to begin with because it goes on spontaneously. But there are two major issues here. One is the diameter is too big. I think it needs to be improved. And the second is that wherever it feels some resistance, it stops because there is an automatic sensor around that. And then if it feels little bit of resistance, because they want to play safe, they don't want to end up in a complication. That's the reason they have designed it like that. I think so. Any strictured lesion, it becomes a real challenge. Even in a normal esophagus, quite often it stops. So you have to do a balloon dilatation or pass a bougie, and before you introduce the spirus. So there are, in the present model of spirus, there are genuine problems and challenges. And we need to, I'm sure that it will undergo change, and then future it will be the spirus, but right now it is not the right thing.
We had Chandru, one point to add. We had two short-necked patients, both were females, and where we could not pass the spirus through the cricopharynx after 18 French dilatation. So that became a problem because the stub that attaches the overtube to the endoscope, that is thick and it's unable to cross the crico, even after 18 dilatation. So that is sort of problem.
Mohan, did they have stricture?
No stricture.
What will you dilate then?
No, you just pass an 18 French boogie, it's a regular dilator prior to the passage of the scope.
So let me clarify that point, TSC. Yeah. Even if there is no stricture, some people dilate the esophagus before starting the procedure for a smooth passage. And as rightly pointed out by VG and by Ajay, sometimes you get stuck in the esophagus itself. So I think having said that, it's a great potential. And I'm sure with a few cases being done by all of us, we would not have major problems. We all had problems when we started double balloon enteroscopy in the beginning, but I think it's a learning curve which we'll cross very soon. And I sincerely think that in the next 5 years, we'll be hearing more and more about it.
I want one word answer from all the speakers and moderators and commenters. The question is by a person from this part of the country again. Which balloon will you choose? I'm asking about double balloon, single balloon, not the other balloon.
Single balloon.
So SP, why, which balloon and why? One word answer.
Single balloon, easy to use, similar results.
Okay, number one. Okay, you are done. Nagesh?
Better imaging.
We have both double balloon enteroscope and we have double balloon and single balloon enteroscope in the department, but we have not used a double balloon in the last 2 years. So that answers the question.
Yes.
That is good. Mohan, both balloons are with you now.
Single balloon because of the ease of use.
Ease of use. Ajay?
I do with double balloon because I'm more used to it. Otherwise, I don't have any specific like or dislike, but that's what I'm used to.
Govind, what is the preference in All India Institute?
We are both, but more often we use single balloon.
Single balloon. Now the question to Govind is, which is the best test to differentiate Crohn's and tuberculosis non-invasive? Is there any test available?
There is no test. A good history. Very good history will give you a lot of point,
No,
which will tell you. And second thing, non-invasive, then we tend to do a CT scan, CT chest, and we found that 30% of the patient where X-ray is normal, the CT shows either old or new lesion. And there are 2 papers published by Vineet. So we have a protocol that all patients, we have a CT to differentiate these two. Because this also helps if it's Crohn's.
I would only add TSC that CT has its value as Govind said, but if you do an ileocolonoscopy, which I don't think whether we'll call it an invasive test any further, in majority of time with your experience, you can say in the first go itself that whether you're dealing with tuberculosis or Crohn's, I would put that figure somewhere around 85%. You can easily differentiate by a colonoscopy after experience.
Okay, many postgraduates are watching this. Mahesh, you said colonoscopy wise, you will be able to differentiate TB versus Crohn's. How will you?
So I think a very important point is ileocecal valve involvement. If ileocecal valve is involved, then you would usually think more in favor of tuberculosis than Crohn's. If ileocecal valve is not involved, then you think more of Crohn's than tuberculosis. Whether it's a longitudinal ulcer or transverse ulcer makes us understand whether there's skip areas or no skip areas. All these features taken together, no one parameter, and Govind will agree with me, while it may not be one parameter which is going to decide, a combination of parameters in the background of a good history and some imaging would help us. And I can say from my experience that about 90% of the time, you can decide whether it's tuberculosis versus Crohn's. If you do not reach a diagnosis, and I would want Govind to talk on that, if you do not reach a diagnosis, I would err on the side of treating for tuberculosis rather than Crohn's, and then reevaluate the patient after 2 to 3 months.
The question to all panelists, we are not able to decide about it's indeterminate. We are not able to make it tuberculosis or Crohn's. How many of you would go for the empirical treatment of the tuberculosis?
I would go for empirical treatment with tuberculosis.
Ajay?
All of us.
All of us.
We can add the guidelines now. They are both Indian guidelines based on data from IBD Clinic of AIIMS, and Vineet published this paper in APT 4 years back. Also, this is a guideline by Asian Pacific Association of Gastroenterology. Both suggest that if you have a patient where you can't differentiate TB and Crohn's, you treat for TB first, give 4-drug regimen for 2 months, review this person. If he's improving, he or she is improving, continue it. If he's not improving, then again reinvestigate. And if you're improving, then go till 6 months, and most patients would improve.
The problem is
all panelists starting from Govind. Now, is tropical sprue existing?
Yes, it does. Yes, it surely does, but not in the numbers which we had earlier. It happens still. Dr. Ramakrishna tells us that he often sees patients with tropical sprue. But what is tropical sprue? Tropical sprue, say 20 years back, was different. Tropical sprue 20 years back was anybody has malabsorption. We had just one diagnosis. You remove Giardia, and all rest is tropical sprue. Because we did not investigate for celiac disease, we did not investigate for a common variable immune deficiency, and we did not invest for any other etiology. But now we investigate to much more farther. We look at, and therefore tropical sprue now is a disease exclusion. So before say tropical sprue, we have to go through a battery of tests before you commit a tropical sprue. Therefore, number has gone down. Certainly we have water sanitation has improved remarkably. The food sanitation has removed remarkably. Therefore, tropical sprue is much less. Even in Bangladesh, tropical sprue is now much less.
How about in Allahabad, in SP?
Yeah, we hardly see tropical sprue now because celiac was not a possibility about 30 years back. So we were probably clubbing everything together. Celiac and IPSID and all those things have come up. So there are many more diagnoses coming up rather than tropical sprue. Going to you, one question. Many patients of Crohn's also improve on ATT. That's the problem.
Again, this is data from Vineet that he showed that those who have an empirical trial of ATT, because the symptom will improve. The symptom will improve, the fever will get better, they will feeling of general well-being, the blood will also get better, pain also gets better. But if you do colonoscopy in them, there's no healing. The lesions persist. And that's what we say that this is not tuberculosis. With tuberculosis,
you have to do a colonoscopy after 3 months.
Not really 2 months, then do a 6 months. So do a symptomatic scan at 2 months. Unless required, you do a repeat colonoscopy, but probably we do much later because being an invasive test, we generally do it.
So once you do it later, you will end up with more strictures.
There are 2 papers, one from Rupa Banerjee from AIG, and also paper from us. They both are both direction.
See, we follow, if I can share our own way of protocol, we always do an ileocolonoscopy after 2 to 3 months in these patients. And in those where we are not sure whether it's tuberculosis and Crohn's. And as rightly pointed out, if there's a significant improvement in the ileocolonoscopy, we would label this as tuberculosis rather than Crohn's.
All agree for empirical, there's a role for empirical therapy. But what about in Coimbatore, tropical sprue, BGM?
Chandru, we don't see much of tropical sprue now. Even though Uday Ghoshal has shown the IBS to SIBO to tropical sprue, the malabsorption spectrum as a continuum.
Our hygiene has improved.
Possibly. SP knows all our villages and towns in Coimbatore.
Anything going COVID-19 and small intestine, the malabsorption, anything has been demonstrated? Anything?
Yes. Diarrhea as a presentation in 11%.
We are now in COVID-19 era, so we should not forget that. So what is your opinion about that?
So,
as a question from another delegate.
See that here we know that COVID does affect multiple organs. It started from the lungs and upper respiratory tract, but now we know it involves small intestine, it involves heart, it involves many other organs. There are data available both from autopsy and this thing. And it also involves small intestinal mucosa like any other viral infection. And many of the, almost 30 to 40% of patients with COVID, acute COVID infection, acute SARS-CoV-2 virus infection have GI manifestation and liver manifestations. At least 30% have raised ALT and about 20% do have a diarrheal disease. But they all get better. So probably they also have the AC inhibitor, AC receptors are there in the small intestine that it affects. It also has a lot of bearing on the IBD. And there are a lot of group working on the effect of Crohn's on IBD, SARS on IBD, and this are now being published. Also, the paper that patients with Crohn's celiac disease are also predisposed to coronavirus infection. Yes.
I think, Chandru, I think we'll have to wait for some more time to see if these guys who develop diarrhea as an acute presentation develop malabsorption. I think we'll have to, time only will tell us.
But there is available no one. Those COVID patients had GI symptom. Those who did not have GI symptom, predominantly those who had GI symptom had very severe COVID. Morbidity and mortality was very high compared to the COVID patient who did not have morbidity and mortality. I mean, they had less morbidity and less mortality. So there is clear cut. But as a presentation of COVID GI manifestation, only 2 to 3% only.
We are seeing some patients who have only GI manifestation, diarrhea, they present with diarrhea or erased ALT, and then you tested that they're COVID positive.
The question to you, Govind, what is the role of now the hydrogen blood test?
State again, sir, what is the question like?
Hydrogen blood test.
So certainly this is a very important test and two contexts. The first context is those who have you're thinking of a small intestinal bacterial overgrowth. Then you would like to do either glucose or lactose hydrogen blood test, and which is confirmatory test for SIBO. And second one, that if you're suspecting lactose intolerance, then do a lactose tolerance test. For these two, this test is mostly done.
Okay, now rapid fire. We have a lot of questions now. Dr. R.A. Kedia from, what is the rough estimate of acute and chronic amoebiasis in metros and smaller towns? May not be related to this.
Nothing
but, in metros and smaller towns. Any idea about this?
I have objection to the term chronic amoebiasis.
Nothing chronic amoebiasis. It's
There's nothing called chronic amoebiasis.
Acute amoebiasis, you are right. And
so if you can add a word, if you add a word, this is a paper by Dr. A.C. Anand where he said there's no term like I published in Lancet that there's no term like chronic amoebiasis. Those who have a entamoeba dispar passing is stool.
Dr. Anand published a similar paper like that. We were, Ajay will remember that we were in
GVP. Pointed question to Dr. Govind. Does amoebiasis produce immunity or not? Why you are getting recurrent amoebiasis?
Those are IBS cases, they're not amoebiasis.
Amoebiasis is only when we have hematophagous evidence of that.
I don't think there's immunity to
I remember
amoebiasis.
now when I was doing
IBS
TB.
today, symptomatic cyst passers, that you are using the terminology
Yes.
as a chronic amoebiasis. They're basically asymptomatic cyst passers. The
Yes.
only reason to treat them so that they don't become carriers or pass on, communicate to the others, or they do not soil the water and this thing. Otherwise, there is no direct correlation between that. The huge
Govind,
study.
anybody is doing Zymodines now?
I'm not sure, sir. So,
Okay,
not at
no
AIMS.
webinar will be
Not at AIMS.
no webinar will be complete without Rajesh Gulati's question. Now, question pointed to Mahesh. What do you think when will 50% of Indian gastroenterologists be able to perform spiral endoscopy during their lifetime, keeping in mind cost of equipment?
No,
So I do not have the crystal ball again, but I don't think this will ever reach, and we do need to reach 50% figure. I think we should develop some centers all over the country where this facility should be available. And I foresee in the next 4 to 5 years, at least 40 to 50 centers having that, and that will fulfill the requirement. I don't think each technology needs to reach to each place. If we can develop some center of excellence in each locality, that's good enough. So I think this
I will
answer.
add on to you, Mahesh. I don't think 50% of gastroenterologists need to do this.
That's what I'm saying. That's why I'm
the
saying.
number of cases will be very limited. Only tertiary care centers, you can have a referral point. I was talking to Ping Joe. I was asking, how did you do so many athalasias? He said in China, there is a policy that all the achalasia in and around that area will be referred to him. And that way he is able to produce a more number of expertise and training and the papers, publication, all these things.
In
If
Germany,
every center is going to have a spiral endoscope, then there is no point in doing it. I think the answer should be.
I would also make one more point on TSC about the history of Spirus enteroscopy. Till 2009, this was with a company called Spirus. And this is at that time that with a normal endoscope, you can use just buying the overtubes. Now it is with Olympus, and they have integrated the whole system into one system.
It's
And that's
6
why it's
o'clock.
become costly.
Yeah. Now the question from Dr. Subhayami Das. Can AI be used in MR enterography in future?
Artificial intelligence?
Yeah.
It's already being used. Let me tell you, a number of seminal works is going on. In fact, we had a discussion yesterday about using it in MR enterography with an Indian group from Texas. So they are looking at using it for MR enterography. They're using for everything. I think artificial intelligence is going to be used, and it's very easy. It's very easy. You just need to feed a lot of information to the computer, and the computer, with the help of CNN, will generate its own way of looking at it.
Chandrasekhar, my nephew is working on that in Texas, the group he was referring to.
He is working on AI in
AI and radiology.
AI and radiology. Okay, question from Dr. Hamid Reina. He is going to come an excellent presentation by both the speakers. My question to Dr. Govind sir is, what is the cause of celiac disease in children? Time of introducing wheat or total amount of wheat in first 2 years after weaning?
So this is a very active question in for those celiac freaks, that is the time of wheat introduction is important for celiac. And there are two studies which are from TEDdy group. TEDdy group looks at those risk of type 1 diabetes, how they develop type 1 diabetes. So there's a big cohort of patients in Europe, and in these children we are looked at, seen that if you give, there's no such, it doesn't matter, but only suggests that don't give wheat before 3 months of age, because by the time your intestinal barrier is not mature, therefore all the antigen will cross through, and you will have a minimal disease later. So now dictum that don't feed your child in very early wheat and wheat products. At least wait for 4 months.
The question from Dr. Sitaram Chaudhary from Nepal. Question to Dr. Mahesh. Dulofy in small intestine. Experience of experts, please.
I think we all know that the commonest site for Dulofy is in the stomach. 6 centimeter below the G junction on the lesser curvature posterior wall. But we have all seen occasional cases of dolichosis occasional cases of dolichosis everywhere from cecum to the small intestine. Now, the point is that you need to have differentiation of these lesions from the usual ABM malformations, which are more common, and from small ulcers, which can sometimes be diagnosed as dolichosis ulcers.
Okay, now same Dr. Subaima Das is asking you, Mangesh, can spiral be attempted in children?
No, not in small children. Not in small children. I think people have done it in children as small as 10 to 11 years. But I think in small children, because of the reasons which we discussed, with a wide diameter, it will be wrong to use spirus at this moment in children.
Okay, lot more questions. I'm going to choose some questions only. Dr. Pranab Kumar Mandal to Govind.
From Ranchi.
Whether from
Ranchi.
Whether durum wheat and bread wheat has a difference, and what is it? Genome. Is there any difference in genome? I think must be familiar with the question now.
No, thank you, Pranab. Pranab is my collaborator. He's a agriculture scientist.
That's why he's asking very specific question, I think.
So he knows that durum wheat wheat has three types. Durum is a tetraploid. Earlier we had diploid wheat about 10,000 years back. Then we had tetraploid wheat, and then we have hexaploid wheat. The wheat we use now is a hexaploid wheat. The durum is a hard wheat from where we make pasta. But again, the study is available that durum wheat also has alpha and gamma peptides, and they are immunogenic of celiac disease. So they are not safe for celiac. Durum is not safe for celiac.
How will you differentiate non-gluten and gluten enteropathy?
There are two different things. Celiac disease, celiac, it means there is a mucosal damage, and therefore damage induced malabsorption. Non-celiac is most likely an innate immune response to some gluten peptide. So they will have symptoms, but there's no enteropathy. It is no advanced enteropathy in them. And the whole area needs to be explored further. It's too early for non-celiac, and the till now non-celiac diagnosed in those patients who have symptoms of diarrhea, pain, discomfort, fatigability or so, and they respond to gluten withdrawal in double blind form. Only those, but there's no blood marker at this point of time. Unlike celiac, we have a TTG, but for non-celiac, TTG is negative and there's no enteropathy.
AC, we should leave some questions for the next session.
Yeah, two more questions.
Otherwise, Sethu Babu will kill all of us.
No, that's okay. We can manage that. The question is, how will you manage congestive enteropathy?
I think if you are talking of congestive enteropathy, and TSC, you have some work on capsule endoscopy in portal hypertensive enteropathy, and then we had another article which was published in the Korean journal. I think it's a very important entity which we do not talk about, and there's a very disgusting also that some patients with portal hypertension who has already esophageal varices have been taken care of, they continue to bleed. So we have now a series of 50 odd patients which we presented. These patients, we now do capsule endoscopy in all patients, and after localizing the site, if it's approachable, we go with a small bowel enteroscopy and try to cauterize. But because it's a diffuse disease, sometimes they tend to recur, and we also give them drugs like octreotide or long-acting octreotide on these patients, but these are very difficult patients to treat.
Nothing doesn't work.
We are coming to the end of the session. I have two questions from my side, and just to wind up the session. What is the most difficult small bowel case you ever had? Starting with a VGM. Brief.
Okay. The most difficult small bowel case, maybe the strictures, because the Crohn's strictures. See, what we find is that with the capsule endoscope I used to see those days, the crescentic semicircular ulcerations, those patients who had, they developed stricturizing Crohn's later on.
So yours
compared to the aphthous stomatitis.
Crohn's disease. Magesh.
Obscure GI bleed. I think it's very frustrating sometimes.
That is the most killing, actually.
I think very frustrating sometimes. This may be a small number, but it's very difficult to satisfy the patient that in spite of so many armamentarium which we have, in about 2 to 3% of the patient, we're still struggling to find out the cause and to treat these diseases. So I think small bowel bleed still continues to be a challenge for us.
I had a patient with dolichoid lesion bleeding in small intestine. use clips, 3 times done, clipping stops, bleed again. The only advantage we had, we could do an X-ray and pinpoint the lesion, and the surgeon resected only a small piece. So that was the advantage we had with putting clips, but very frustrating for that patient.
Ultimately,
Visco can clip.
Visco.
No, we didn't have a OSCE at that time.
Uh-huh. Okay. Govindji?
Sir, yeah, in our celiac clinic of a cohort of 1400 odd patients, 5% patients are those we don't have any clue towards. We don't know are they celiac, are they tropical, are they Ipsit, are they Whipple's, and they're still undiagnosed, and we know how to treat them. So they still come to us year after year after doing all investigation, 5% patients, at least 50 such patients, we haven't done anything to them. And I don't understand what they are. Tried everything, empirical trials, everything done, but again, we don't have no. Second one is difficult are those patients with giardia, they, especially in setting of IgA or CVID, they don't respond to, they don't respond to metronidazole, tendazole, whatever drug you give, they don't respond. They keep getting this infection. I know how to treat them. And again, we have 5 such patients. They have giardia infection for last at least 7-8 years, and we haven't cured them.
Okay, Ajay, what is from your side?
Okay. Well, I think the most challenging thing to, of course, is a category of obscure GI bleed. Out of all this, portal hypertensive small GI bleeds are the most daunting to treat.
So we started from stricture and we went into the obscure GI bleed and the celiac and dulophies and having the diagnosis, enteropathy, the portal hyper. I think I agree with Ajay. The portal enteropathy is the most difficult to manage. They go home, they bleed and come back, and we don't have any armamentarium.
I must here talk about Dr. Mishra's article. I think Dr. Mishra was one of the earliest to talk about portal enteropathy.
In 4 to 5 patients of a small bowel hypertensive,
wind up and
What about crisis? Celiac crisis?
No, it's uncommon. So I've seen with children, so I haven't seen any cases. But it's uncommon. But Ujjal has published a couple of papers recently, and Ansu Srivastava from SGPGI, the patient who had still they have patient with celiac crisis.
I'm going to wind up in a lighter sense. The question posed to me, I could not answer till today. I'm not able to answer till today. I just presented my small bowel, the small bowel evaluation that time when I was doing DM. So a gentleman, that was for the public, that is for the general practitioners. The doctor used to be very inquisitive. The doctor stood up. Dr. Chandrasekhar, very nice presentation. I want to ask you one question. If the same patient has got both Crohn's and tuberculosis in the ileocecal area, how will you treat it and how will you differentiate it?
There's no question of differentiating.
Coexisting both Crohn's and tuberculosis. I don't know whether it's a hypothetical question or can do they exist like that, or we are, this is the one I just want to tell you that, is it, can coexist Govind like this?
So I think before Govind takes it over, I think Govind is an expert on this, but we do have patients who are diagnosed as Crohn's disease, classical Crohn's disease on treatment, has been on steroid recently, and then developed florid tuberculosis.
Yes.
So I think this do happen. It's not a very
background
broad
tuberculosis
question.
is so common that you get everything.
TSC has already said it is out of humor that he's asking this question. And this is a question which was asked to Patrick Kamath in the lecture theatre 1.
Patrick Kamath
and it in the same mood that he's asked this question.
Outside this webinar, I will tell you what answer.
I know the answer, but Patrick,
we know the answer as well. We have discussed this over coffee many a time.
Yeah. Then, okay, now we have come to the end of the program. Most important, I must profusely thank our speakers, Dr. Magesh and Govind, and very good commentary by Dr. SP and good moderation. And we had a wonderful session in this COVID. And Dr. Gokul want to say before we sign off.
Hi, Gokul.
Hi, sir. Good evening, everyone. It's my pleasant task to thank each and every one of you. Our sincere thanks on behalf of MedIndia Hospitals and Academy. I would like to express our sincere thanks to the speakers, Govind sir, for taking your valuable time in preparing this difficult topic. We learned a lot from you, sir. Thank you very much. Our sincere thanks to the moderators, Dr. Ajay sir and VGM sir, for giving your insightful inputs in these two topics. I thank Mr. Sir for giving his valuable thoughts and wisdom on these two topics. Thank you, sir, for your expert comments on these two topics. Finally, I'd also like to thank my chief because he conceived this idea of having, we want to discuss this landmark publications because he always feels that our practice should be based on science and evidence-based medicine. Thank you, sir, for having this topics.
Thank you.
I'd also like to thank my colleagues, Dr. Prasad, Dr. Satyamurthy, and Dr. Yogesh for their assistance. I would like to thank Microlab because without their support, this program would not have been possible. Thank you, Jairaj sir and his team for your support. Finally, I would like to thank all the participants, the attendees for watching this program. Thank you, one and all.